So I'm going to be talking to you today about a program called Imagine, which is a partnership that CARE has with the Gates Foundation that is targeted at reducing the rates of first birth among married adolescent girls in Niger and Bangladesh. Now we know that child early and forced marriage is increasing in certain contexts around the world. The COVID-19 pandemic unfortunately showed us data that said that a lot of the work that we had done to reduce those rates previously has unfortunately been undone within a short period because a lot of families, especially in humanitarian contexts, were experiencing financial hardship as a result of not being able to work or losing their jobs, and so resorting back to previously held beliefs about child marriage as a way of essentially selling their daughters for money to be able to afford food. And so one of the things that Gates and CARE were interested in looking at was to say, okay, in the context where this is in fact happening, what can we do to delay the risk that those girls are experiencing and through the maternal mortality? AKA, how do we delay their first birth? Now, I want to preface this by saying that this was a pilot study, and I want us to all put ourselves in the mindset of we are currently about to walk into traditional conservative societies that are mostly rural, where the currently held social belief is that if a girl does not have a child within her first year of marriage, there is something actively wrong with her. So we went in to try and pilot these methods to see, is there a way that we can potentially shift these norms and perceptions? And I would invite you to come on that journey with me. So I shared a little bit about this, but just so that we're all on the same page walking into this story, the challenge that we're seeing here is that 90% of adolescent pregnancies that we're seeing globally are occurring among married adolescent girls. And so is there a way for us to think about the developing initiatives that are targeting that specific aspect of their vulnerability? Because a lot of the programs, as I'm sure all of you know, as per people who are working in CFM, are targeting the actual prevention of the marriage itself. This program was very uniquely focused on what happens after those girls are married. So our objective was to, first of all, figure out if there's even an intervention that could potentially successfully help delay first birth among adolescents. So let's all contextualize our situation. We are looking at a scenario in which we have girls being influenced by their husbands, their mothers-in-law, religious context. Their decisions are not really their own. Delaying childbirth is seen as undesirable and makes a girl unwanted. Healthcare providers are also of the mindset that a girl should be giving birth. And so basically you're walking into a scenario where there's multiple barriers and very few opportunities. But what we did was we created this program called Imagine, which stands for Inspiring Married Adolescent Girls to Imagine New Empowered Futures. And we ran the program in 2 different districts in Niger and Bangladesh over a period of 5.5 years. And so 2 of those years were just spent on our formative evaluation and design. And part of the reason for that was because there isn't another initiative that has been extremely successful across all contexts in reducing first birth. So we wanted to spend a lot of time figuring out what it is that we're dealing with. And then we had 2 years of implementation, and then we did an ex-post evaluation. There were multiple intervention elements that were included in Imagine because, as we all know, in order to change a certain aspect of an adolescent girl's life, you have to also target all of the networks that she experiences, her societal networks, familial networks, the providers at the clinic. You have to try and change the environment within which she's operating and living. So we had our primary intervention, which was called the Girls Collective, which is the actual gathering with the girls where we are able to sort of teach them about the risks of early birth and talk to them about how to negotiate sex and pregnancy with their husbands and mothers-in-law. So a large part of the Girls Collective actually just focused on skills building to say, how do I, as a girl who has not previously ever had to advocate for myself or been able to advocate for myself, now walk into a situation with people who are more powerful than me, and how do I stand up for myself? And so part of the Girls Collective was just very much focused on building these elements of self-esteem and the capacity to be able to sort of even just vocalize what it is that you want to do as an individual. Those girls were also enrolled in vocational opportunities that allowed them to earn money, because one of the things that we have realized through needs assessment is that when you have money, people listen to you. And so the girls, as soon as they started participating in income generation activities for their families, their husbands and mothers-in-law started to grant them decision-making power within their households. And of course, that might not necessarily be a long-term sustainable option, but it was a way of sort of changing the context within which they were holding power within their own households. We also had a transformative component where we were working with health workers for them to be able to shift their perceptions about first birth and think about what it means for a girl to be able to have her own reproductive autonomy and her own say about when to become pregnant. We also worked with dads, so the husbands of the girls. We called them father groups. It only happened in Niger. And they were similar to the girls' collectives, but they were specifically focused on the husbands of these girls, enrolling them in their own curriculum to say, like, what does it mean to be a man? How does being a father correlate to being a man? Can you be a man without being a father? All of these kinds of topics, basically engaging in reflective dialogues to get them to think about how they can be better partners to their wives without necessarily necessitating children as a part of that equation. We also engaged in community SAA groups. SAA stands for Social Action and Analysis. It essentially is a group that brings together key stakeholders within a community, like religious leaders, doctors, teachers, whoever the community deems as their gatekeepers, and engages them in a series of reflective dialogues where they are asking themselves questions like, what collective responsibility do I personally have to change the norms that exist within my community for girls? And then finally, in Bangladesh only, we also engaged in couples counseling with certain girls that were enrolled in the program, where the girls and their husbands came and joined a counseling program, received newlywed kits, essentially received family planning counseling together in addition to the things that they were talking about in their girls' groups. And then we evaluated the program to see if it worked. We had 2 evaluation objectives. The first was, of course, to see whether we actually delayed the timing of first birth. And the second was to understand more qualitatively how participants were perceiving the program. And I'm so proud to tell you that we had absolutely no impact in either country. And I say it that way because I think failing is a really big part of the equation of learning. And you know, there's a lot of information on this graph, but basically what it's saying is that we did not see a significant enough difference between the control and treatment groups in delayed first birth. But let's talk about this for a second. What was happening while this program was going on? The COVID pandemic. In Bangladesh, the COVID pandemic hit extremely hard. There was a massive disruption of health services. In Niger and Bangladesh, it was much harder to shift norms around like long-standing traditions because people were now stuck at their houses. They weren't even able to engage with our programming in certain ways. So while this is disheartening, it's also not that surprising. Plus, we implemented for 2 years in communities that were experiencing COVID that had been doing these traditions for like 200,000 years maybe. So we're simply saying that, you know, this doesn't necessarily mean that it didn't work. It just means that we need to do way more than just a 2-year pilot. And luckily, even though we didn't see a significant impact in delay of first birth, we did see significant impacts with other things. So for contraceptive use, we had a significant increase in uptake of contraceptives among the girls who were part of our treatment group as opposed to the control group. There was a significant increase not just in current contraceptive use, but also ever use of contraception across both modern and traditional methods. So that's encouraging, thank you, to say that, you know, we were seeing these kinds of results, even in a scenario where we weren't necessarily seeing a delay of first birth. Another impact we saw was the difference in the ideal timing for first birth that couples were telling us that they wanted to adhere to. So they might not have been able to, but the perception, it seemed, was shifting. When we asked them to report what they thought their ideal timing was, we saw a significant increase in their reporting of mean months after marriage that they would referred to as the ideal time for first birth in Bangladesh up to 23 months. So we did not see a difference post 23 months, but up to 23 we did see a significant enough difference. And then just through our qualitative findings, we also saw some other shifts in perceptions and norms. So in Niger, there was before the program, a very strong opposition to going to public health facilities to get your contraception among the girls, because there was this fear of, recognition, of lack of confidentiality, of lack of privacy. And they also perceived health workers as the greatest barrier to being able to get contraception. And yet after the program, we saw a massive increase in the use of public health facilities in their region. And that was despite COVID, because those health facilities were still being seen as COVID hotspots. So that was definitely like, there was an indication that, the transformative work that we had done with health workers had been at least somewhat effective, because public perception of them had shifted. We also started to see far more increased communication in both countries about family planning and even just negotiating the timing of sex between couples. We saw that more among couples where the husbands had also been enrolled in the program, but we were seeing it even within couples where only the girl had been enrolled. And then we also just saw improved support for contraceptive use among husbands, which tracks with the fact that we saw an increase in contraceptive use. So, what does all of this mean? There's, of course, a lot of lessons that we learned across the way, especially when the primary objective of the program was not one of the significant impacts that we saw, but essentially we're seeing you have to have long-term programming if you're trying to shift long-term norms, right? I don't think that me saying that is a revolutionary thing, but it is worth stating to say that donors should expect to have to fund programs for more than just a 2-year implementation period to see results. It is unrealistic for us to be able to achieve results within these communities if we're only going in for such a short time. Second, there are multiple constraints that we need to simultaneously address, both supply and demand. That was especially an issue during COVID when supply chains for contraceptives were severely disruptive. And, despite the fact that we didn't see gains in delay of first birth, we did see other gains. And so there's obviously an indication that this type of programming could work if we had implemented it for longer and perhaps in a less pandemic environment. And so some recommendations for potential future programming that is looking to delay first birth among married girls. We would suggest that they focus also on aspects that are increasing the gender equity and agency of those girls in those environments. So not just doing thresholds around age and time or focusing on education that is focused specifically just telling a girl you have to delay. There has to also be something else that is coming in to essentially increase her value and shift the perception of her worth within her society, which as an example is where the vocational opportunities that I was mentioning earlier came in. And finally, one of the things that we learned over the course of our longitudinal analysis was that if you are trying to delay first birth in a context where the unmet need is low but use is high, one of the things that is actually very crucial to this whole equation is improving the quality of services that adolescent girls are receiving at facilities. So not just availability, but also the quality and the confidentiality and privacy. So that's all for now, and I will happily take questions.
Thank you, Pari. Please stay. So for me, I'm sure you've all taken away messages from this presentation. The 3 messages that I take away, one, they did 2 years of formative research. So, they took time to understand, which is a real privilege, you often don't have that much time. Second is they put in place a multi-component intervention. You didn't talk very much, Pari, about how the findings flowed into the multi-component intervention, but I'm absolutely sure that you must have thought this through, and it was useful to see this as a socio-ecological framework, working with the girls themselves, but all the other layers. And findings such as this are important. It's not surprising that you don't see a change. Yesterday, we presented large-scale scale-up of contraceptive programs in Chile, Moldova, and Ethiopia. It takes 15 years. It takes 15 years, 10 years, 15 years to make large-scale change. And these things are deeply ingrained, so a very important message. So I'm now going to take one or two comments from the floor, and just, you have your hand up, so you're welcome. Very quick comments, please. Gives us then an opportunity.
All right. Thank you very much, Pari. It's always interesting attending your sessions. For me, this is the third session I'm attending when it has to do with adolescents and then access to family planning. And I discovered that most of these research or these studies, you create demand, but you don't look at the supply aspect. And when you create this demand, these people walk into the facilities to try to assess family planning, and there is no family planning commodities. And then that is not captured in the register. And that will also affect your outcome, because if there were commodities to purchase, then you see that would also increase, and then probably significantly affect this. And then when you talk about the control and the test, I was wondering, at what point did you compare the test to the control? Is it at the end line, and you just look at, is it a point comparison, or a period comparison, maybe looking at the control from what was baseline to end line, and also looking at the test? Because for COVID might have yes, affected this, but maybe without COVID, these test sites would have even performed worse than that. But if you're using a test point, you would not know what was baseline for the control, comparing it against the endpoints. Thank you.
Thank you. Question on what systems were put in place in these two sites, and then on methodology.
Thank you so much. I'll be brief, actually. I'm Tayech. I'm a faculty at the University of Global Health Equity. I just want to ask about the gatekeepers. You described you listed some of the gatekeepers, but do you see any change on who the gatekeepers are these days?
Any comments from here? One quick comment from anyone? Yeah? Okay. So we'll stop after.
Okay, so just a quick question. Do you still work in those communities, and do you have any plans to go back there? Because sometimes when you do like an immediate review, you might not see any changes, but long term there could be some changes. So do you have any plans to go back there, or do you still work there?
Thank you. Last quick comment, Ahmed. We'll come back.
Okay, thank you. Thank you for showing the results of this intervention. And I think I can see how the thinking process went into designing these components, especially that working on items related to gender norms and trying to transform them as well, even if we're focusing on a clear sexual reproductive health outcome. My question is, in some context, it might be difficult to focus only on delaying first birth. At any time, did you think of including adolescent mothers and delaying of other births or spacing birth as well?
Thank you. You had your hand up. Last comment.
It's actually a question. I'm
free to come forward. They're a small group.
I'm Danica from the Philippines. So you mentioned that there's no significant impact in delaying birth in both countries. So I just want to know what would you have changed then, given the given the COVID-19 pandemic context?
Thank you. Two or three quick responses. We can come back to some of these issues about methodology, about coming back to long term at the end.
Okay. Francis, so we collected treatment and control at baseline and endline. That's a quick response. UNFPA paid for commodities to be present at facilities, so there were actually commodities despite the supply chain disruption, which is, I think, why we saw increases in contraceptive use despite COVID. We would love to be able to go back to Niger and Bangladesh. CARE in other countries has a policy of doing an eval 6 months after and 1 year after. Unfortunately, our Gates Foundation funding is running out for this one, but we are currently in talks with them to attempt to continue. Okay, the question about birth spacing, the answer is no. We could have looked at that, but Gates, and I think many of us in this room have worked with Gates. They're a wonderful found donor because they have strong technical knowledge. one of the things that they were very explicit about when we were designing Imagine was it has to be about delaying first birth, because that is the whole, like the unique aspect of this program. So that was what we looked at. So the ways in which we looked at other aspects were the other indicators that I showed, the family planning and determinants and decision making. But I do think that that's an opportunity that we probably could have explored. Could you remind me what the question from the Global Health Equity faculty was? Oh, yes. Did the stakeholders change? The gatekeepers, yes. You asked, did the gatekeepers change? The only thing that we saw was that mothers-in-law had slightly less say than previously. So I wouldn't say it was a significant enough shift in who the gatekeepers were. The husbands and mothers-in-law were still there. And what would we have done differently? We would have run the program for longer and hopefully not during a pandemic, or we would have had a different adjustment to allow for pandemic preparedness. But I think it's safe to say, as Chandra said yesterday, I think most public health failed when it came to responding to COVID, and this program, I think, probably was impacted by some of the constraints that came in during that time.
Wonderful responses, Pari, and clear, concise responses. Can we give her a big hand? One of the nice things about having Arvind here from Girls Not Brides is they run a research sharing network called CRENC, and maybe Arvind, you can say a little bit about that. And so maybe one of the themes of that could be this, recent research on working with child brides. Okay, we move to Marie Habito. She's from the Philippines. She works with the Burnett Institute in Melbourne, and I think your presentation is about scoping review in Southeast Asia, right? Go ahead, please.
Can I have my slides, please?
Pathways to adolescent pregnancy in
Yes,
Southeast Asia.
that's correct. Okay. Thank you. Right, good morning. Thank you everyone for being here. My name's Marie, and on behalf of my co-authors, I'm here to present our abstract titled Understanding Pathways to Adolescent Pregnancy in Southeast Asia, which is a 4-country qualitative study with adolescent girls in Indonesia, Laos PDR, Cambodia, and Malaysia. So very briefly, let's establish the context. Every year in Asia Pacific, there are 3.7 million births to adolescent girls aged 15 to 19 years, and many more adolescent pregnancies. There is emerging evidence from Southeast Asia that indicates that up to about a third of adolescent pregnancies are conceived before marriage or union. So while programmatic and policy responses in Asia Pacific have aimed to address child marriage and early union to reduce adolescent pregnancy, subsequently it seems that addressing adolescent pregnancy may also help reduce child marriage and early union. However, there is currently a lack of nuanced evidence identifying the drivers of adolescent pregnancy beyond early marriage in the Southeast Asian context, particularly young women's pathways to pregnancy outside of marriage. So furthermore, there are a few large-scale studies into adolescent pregnancy which capture the perspectives and experiences of the young women themselves, which should be central to the design of policy and interventions. So this study, within this context, through funding from UNFPA Asia Pacific and UNICEF East Asia and the Pacific regional offices, we conducted this study to understand the drivers and pathways to adolescent pregnancy in Southeast Asia to inform effective policy and programming responses. Specifically, we aim to explore in depth the drivers and pathways that lead to adolescent pregnancy in Southeast Asia and their relationship with early marriage, and to co-develop with adolescents some specific policy and programming recommendations to effectively address adolescent pregnancy. Our study was conducted in 4 countries, the 4 countries I mentioned earlier, and implemented in each in cooperation with local partner organizations and in cooperation with UNFPA and UNICEF country offices. In each of the 4 countries, our study design involved 5 phases. I'm happy to answer any questions you might have on our study design, but in the interest of time, let me draw your attention to phases 2 and 4, which were our data collection phases. So in phase 2, we conducted participatory timeline interviews with girls who became pregnant before the age of 18. And in phase 4, we conducted follow-up phone interviews with a subset of girls who participated in phase 2 to validate our findings, clarify interpretations, and to gather participants' suggestions and recommendations on how to help girls. Currently, the study is in phase 5 in Cambodia and the tail end of phase 4 in Malaysia, and both will be wrapping up by the end of this year. Across the 4 study countries, we conducted a total of 261 individual timeline interviews with girls. We endeavored to recruit a mix of participants from rural, peri-urban, and urban communities. And all interviews were conducted in the local language by trained female interviewers who were native speakers. So to the right is an example of a participant's timeline. We used a blended inductive-deductive framework analysis approach to identify pathway topologies in each of the 4 countries, and to develop an understanding of key drivers of adolescent pregnancy grounded in participants' experiences. To date, we have conducted a total of 58 follow-up interviews. We're waiting on the last few from our team in Malaysia. And having identified the pathways in each of the 4 countries, we have integrated our analysis to conduct a regional analysis to identify pathways across the countries. These are the findings that I'll discuss in the succeeding slides, noting that this is still very much a work in progress. So pathways were primarily differentiated by the timing of pregnancy relative to any union, and by union we mean marriage or cohabitation or living together while not formally married. We paid attention to a further set of factors under each of these 2 categories. So under pregnancy outside of union, we paid attention to the context of sex before pregnancy, contraceptive use, pregnancy intention, and who made the decision about entering a union or not, and the relationship outcome following the pregnancy. So was there a union or was there no union? For the pregnancies within union, we looked at who initiated the union, specifically looking at whether the girl had some or little or no say in that decision. We looked at the context of sex before pregnancy as well, contraceptive use, and pregnancy intention. So this is a very rough set of next tables, but in the following slides, I will be showing the presence of certain pathways in each of the countries. We're still refining our analysis to take a deeper look at the frequencies of each pathway to gauge which ones were most common across all countries, but I'll do my best to provide some insight based on the data we have. So under the broader category of pregnancies that occurred outside of any union, we observed forced sex pathways to adolescent pregnancy in all countries, but it was particularly common among our participants from Indonesia, where many girls reported being drunk, drugged, and unconscious during rape. Also in Indonesia, many girls were compelled to marry the partner who raped them, typically to protect the girl and her family's reputation. Pregnancies following rape were, of course, unplanned, and in Indonesia, Laos, and Cambodia, often followed by a swift parent-led union, which was usually marriage. A few girls from Indonesia, Laos, and Malaysia who got pregnant following rape refused to marry the person who got them pregnant. Also, out of union pregnancy pathways, we observe pathways through experiences of sex. We refer to it as pressured sex, but by this we mean the girl reported being emotionally pressured by her partner to agree to sex and eventually relenting, or being under the influence of alcohol or drugs when they agreed to sex or relented. Pregnancies in these pathways were all unplanned. And in Laos, pailen, or going out and partying, was often brought up when describing the context of their first sexual experience outside of union. Notably, none of the girls in Cambodia aligned with these pathways, and no contraceptive use was reported by girls in any of these pathways. Pregnancies following consensual sex outside of union were usually unplanned. but some were described as wanted or intended by the male partner, and a few cases were intended by the couple to facilitate a union. So this was usually when their parents objected to their relationship or refused to let them marry. Compared to other outside union pathways, girls who aligned with consensual sex pathways reported some contraceptive use. However, contraceptive use typically entailed using condoms initially and then quickly discontinuing in subsequent sex. Or stopping a method because they feared side effects or their partner didn't want them to use contraceptives. In these pathways, male partners' promises that they will take responsibility for any pregnancy were key to convincing girls to stop using condoms. Some male partners simply refused to use condoms, but they did not feel, because they did not feel comfortable using them or felt that it reduced pleasure. Most girls in these pathways entered parent-led unions soon after pregnancy. So no union pathways, we observed the most in Malaysia, where girls either chose or were forced to become single parents because either their partner ran away or their parents refused to allow them to marry the partner. In some cases, girls put up their babies for adoption, which was not observed in any of the other countries, only in Malaysia. So briefly, for the within-union pregnancy pathways, we have split the pathways into two groups according to who initiated the union, because we want to differentiate between unions where the girls had at least some say in the decision compared to girls who had little to no say. In the first group of within-union pathways, pregnancies resulted from consensual, expected, or pressured or forced sex. Expected sex was described as a wife's duty by our participants in Indonesia. And pressured sex was typically described as emotional pressure from husbands, particularly when girls didn't feel that they were ready to engage in intercourse on their wedding night. There were a few cases of forced sex or marital rape reported by participants in Laos and Cambodia, whereas notably in Malaysia, girls only reported consensual sex, though pregnancy intention varied. Some were wanted mainly by the husband, some were planned by the couple, and others were not planned, but often wanted. And the second group of within-union pathways to pregnancy were through partner or parent-led unions, and we defined this as unions where the girl described having little to no choice. For example, some girls described that the union was initiated by the partner and agreed to by her parents, and they were asked afterwards, but were usually expected or convinced to accept the proposal. So here we see the same range of contexts of sex and agency, where some girls went on to have consensual sex with their husbands even though the union was parent-led. Others had expected sex to fulfill their perceived duty as a wife, and others experienced pressured sex, and a few girls from Laos and Cambodia also reported marital rape. There was little to no contraceptive use in all of these within-union pathways, in this one and the previous one. Those who had used contraceptives typically stopped to get pregnant, which then led to a couple or a partner-led pregnancy, or stopped using contraceptives due to side effects, then had an unplanned pregnancy afterwards. So as you can see, girls' trajectories to adolescent pregnancy in Southeast Asia are quite complex, and we will continue to develop this analysis in the coming weeks and months. Across the pathways, we observe some important factors contributing to adolescent pregnancy in all study countries. So first, most girls lacked knowledge about sexual and reproductive health, including contraceptives, before they got pregnant. In general, girls tended to receive more information after or around the time that they were about to enter a union or after they had given birth the first time. Many girls face barriers to contraceptive access and use. Some of these include shame, stigma, and power dynamics between girls and their partners. And there were clearly constraints on girls' agency and decision-making power, such as in contraceptive use and the timing of sex and pregnancy in their relationships for both within union and outside union pathways. Many girls seem to struggle to assert their sexual and reproductive choices. Sexual violence and coercion was observed across contexts, but were more prominent contributors to pregnancies outside union compared to within union. And finally, harmful gender norms that support child marriage and male dominance in intimate relationships were facilitating pregnancies within and outside union. Through our follow-up interviews, we gathered girls' recommendations for programs and policy in relation to addressing the factors contributing to adolescent pregnancy. So first, girls said that they need access to adolescent-friendly sexual and reproductive health information and services, such as simple, easy-to-understand information and non-judgmental friendly healthcare. Second, they said they need life skills training, including how to have discussions with their partners so that they can assert their sexual and reproductive health, sexual and reproductive choices and their rights. And third, they believe it is important to include boys in the discussions about the importance of contraception and listening to and respecting girls' decisions. And finally, they feel that it's important to challenge gender-based sociocultural ideals and norms, that it is good to marry young, and that contraception is not good, and they feel that marriage is not the solution to unplanned pregnancy. Specifically, girls from Laos said that people in the community should understand that sex is normal and that young people should know about it. So our findings provide new insights on the many pathways to adolescent pregnancy in Southeast Asia and demonstrate the need for targeted interventions. The pathways show that early union can be an antecedent or a response to adolescent pregnancy. Policy and programming focused on reducing early marriage alone is likely to be insufficient to achieve targets for adolescent fertility reduction. Young women navigate complex social environments where they often struggle to exercise agency in their relationships and in regard to their SRH, and these need to be considered in crafting and implementing strategies to address both child marriage and early union and adolescent pregnancy. So practical sexual and reproductive health information, access to contraception is restricted for many, with shame, stigma, and power dynamics exerting strong influence over young women's access and use of SRH services and supplies. Meanwhile, sexual violence and gendered social ideals and norms limit girls' choices. Last slide. In closing, our findings affirm that family planning policies and programs in Southeast Asia need to be tailored to girls' contexts, and different interventions will need to address the many pathways to adolescent pregnancy identified in this study. Policies and programs should be informed by young women's stated priorities and include adolescent responsive SRH information and services, life skills training, social and gender norms transformation, and efforts to address gender-based violence. We believe that future research highlighting the prevalence of the pathways we identified is warranted to help target policy and programmatic response and guide investment into addressing adolescent pregnancy in Southeast Asia. Thank you.
That's a hugely powerful piece of work. The message, one message I take away is that premarital sexual activity is occurring, and young women are completely unprepared with information, skills, and the context around them is also not supportive of providing them with the services they need, the information they need. It's almost this denial, it doesn't happen in our culture. In our culture, sex happens only in marriage, and it's always respectful. And the reality, as you see here, is so very different. 2 or 3 voices. Can we have people who haven't spoken before? I'll come back to you. Any other comments, questions? Would you like to say something, anyone? Any questions? Yes, please. Arvin, and then you.
I guess it's kind of a comment more than a question. I think what's really striking is the lack of agency that's coming through, that girls are really struggling to exercise their rights. And so I guess I'm kind of curious about, there was the distinction between forced sex and coerced sex, and I'm just wondering to what extent girls are actually even maybe able to determine the difference for themselves, and what kind of response would be required differentially in each circumstance anyway. So just a bit of complexity there, I think.
Yes, expected sex, pressured sex, forced sex. So it'll be useful to have you comment on that.
Okay, thank you very much for a very insightful presentation. My question is whether you have considered the age gap whether if they are married, the spousal age gap, or the age gap, and what was implication of that in the recommendation. Thank you.
Any other voices? Any other comments? My question to you is about ethical considerations in research. You spoke to people, a young woman who were pregnant, who was 16. So in many cases, they were minors. And if this is coerced sex before the age of, the legal age of sexual initiation, this was statutory rape. How was this addressed at all?
Okay. So, thank you. Very good.
Quick comments.
Yes.
And then we
very-
have one more.
Very good point about agency and how girls differentiate their experiences of sex. That's why we felt that it was important to tell the story based on how they told us, how they described their sexual experiences to us. And for us, of course, we have our own definitions. We have, references that we can go to define what we think is forced, what we think is consensual. But for them, it's a lot more gray. They would describe having consensual sex, but then saying, oh, but I had had several drinks, but I still consented. So it's, it was difficult for us to not overrule how they described it, and we just tried our best to represent the girls' voices in the way that we described our findings. Second point about the age gap. We did part of our analysis at the country level, so this analysis is the regional analysis, but we've also done individual analysis for each of the countries, and we do go into the age gap. There are specific pathways where there were bigger age gaps than others, particularly those that were financially or culturally motivated unions. And off the top of my head, I can recall that was particularly prominent in Indonesia and I believe in Cambodia. But if you would like to know more about in more detail at the country level, we will be publishing the results of the specific country analyses in the coming months. And finally, ethics. We did apply for ethical approval from the Alfred Hospital in Australia and in each of the local countries where we conducted our study. We argued that we recognize the evolving capacity of girls to be able to provide their own consent to us to participate in the study, but also we had mandatory reporting and distress protocols in place. So we coordinated with our local partners to make sure that if there were these cases where girls needed support, that our local partners were equipped and they were aware of how to approach it so that support could be extended where it was needed.
You interviewed about 250 girls. How many of them actually sought help for this?
I would have to get back to you on that.
Now, this is also, of course, a big problem, not just with your study, with all our studies, because, once you involve the police and criminal justice systems, you have all kinds of other problems to deal with.
Yes.
Thank you very much once again for a wonderful study. One of the really nice things that has happened in the adolescent health field is there's money on the table for the first time. In the last few years, we have the Global Program on Child Marriage, which is hugely resourced. We have also lots of programs funded outside the context of the global program. And so these findings will feed into programming, not in 10 or 15 years, but now. When we finish, I'll ask Arvind to speak to the CRENC network, which is about taking research and putting it in the public arena, even before it makes its way into a peer-reviewed publication, but also then feeding into programs. The third presentation is from Anne Lebot, who's from the Radboud University in the Netherlands, who's going to speak to, I think, contraception and child marriage in sub-Saharan Africa. You have 15 minutes again, and then after that, we'll wrap up with a little bit of discussion and a word from Girls Not Brides.
Well, first of all, thank you all for being here. And also, I would like to thank the organizers because I just started my PhD and this is my first work. So this will also be my first presentation. So your comment. Yeah, thank you. Yeah, so your comments will be very valuable for me because I can still change like a lot of things in the analyses and that kind of stuff. So I hope we can have a nice discussion afterwards. So I will present my work on child marriage and contraceptive use in sub-Saharan Africa, which I co-wrote with my supervisor, Natasha Wagner. So how did it all start? For me, it all started half a year ago by reading this Dutch news article. So I know that a lot of you don't speak Dutch, but the main message was about half of the pregnancies worldwide are unintended, and the UN is concerned about women's rights. So I was triggered, and I started reading this article, and as soon it became clear that this was based on the Seeing the Unseen report, which we probably all know. And then this role for child marriage was pointed towards. So I wanted to point this out by means of this quote. In 54 developing countries with data, the majority of first births to girls under the age of 18 occur within a marriage or union, right? So this kind of points towards that child brides have limited access to contraception or they don't use it, right? So, of course, we all care here, but why should others care? So first of all, understanding the role of child marriage and reproductive health outcomes is essential for effective policymaking and realizing human rights. So for example, population growth is still a huge issue, and also seeing the current crises, for example, like COVID, this is especially relevant and important. And then when I started reading, I also found that there's a lot of inconsistent evidence out there, and also this is challenging the common narrative. So I will come back to that later. First of all, I wanted to point out the severity of the issue. So I planned on using Slido, so you can try to use that, but as we are a small group, it's also fine if I can just get some comments from you guys. So the question is, over the next decade, how many girls do you think are projected to become child brides? So I hope you can open the Slido. Yeah? Okay.
Any quick reactions?
Well, nice. Yeah. So it's 100 million were projected, and because of COVID, there's an additional 10 million. So I just wanted to point out that these crises like COVID, but also civil war, that these are aggravating the situation, and not just the child marriage situation, but also like the health systems, right? Because these are often disrupted because of COVID or other crises. So I wanted to check out this relationship, so I started reading, and the main narrative is that child marriage leads to less contraceptive use. And the narrative is that, well, child marriage is rooted in gender inequality, such as son preference. And for example, it could be that there's an economic arrangement or whatsoever, and this has many consequences, right? So, for example, girls have to stop their education because of social expectations. So they have, for example, to prove their fertility. And this also the age gap could lead to limited bargaining power, right? So this sounds like a convincing story, but then if we have a look at the evidence, we do not see just this, right? We see positive effects, and we also see no effects. So this Fan and Koski paper point out that there is not really consistent evidence, and that the evidence that is out there is challenging common narratives. So the results kind of vary among and within studies. So there's, for example, regional differences, gender differences, but also age differences. And actually, Fan and Koski and others also point out towards the importance of context factors, which I will have a look at in my study. So therefore, the research question in this study will be, to what extent does child marriage affect contraceptive use and unmet need for contraception in sub-Saharan Africa? And then how does the legal system influence this relationship? So just to point out, this is mainly what previous research has been doing, right? I just explained that they have a look at child marriage and the effect on contraception and unmet need, for example, and that here in this relationship, it's not really clear. There's inconsistent evidence. So my argument is that there's context factors that are important, and my focus is on the legal system. So why the legal system? It's an essential approach to combating child marriage. And the argument is that these higher levels, so the legal system at the national level, could influence decisions made at the household level. So, for example, if enforcement is really high, then the risk and costs of child marriage are higher. So this could influence the results, and this is also why countries are encouraged to implement legal age of marriage to be 18, right? But then if I have a look, this does not seem to be enough. So there's often many loopholes existent, and these are existent in more than half of low and middle income countries. So you can think of, for example, that there's multiple laws, so there could be civil law, but also customary law, and these could contradict each other, but also, for example, there could be exceptions. So there's parental consent, and with parental consent, they could marry younger, for example. So when we have a look at this by means of multi-level regressions, which I will explain later, the main thing is that the relationship between child marriage and contraception is still challenging these common narratives, so it's unexpected. But then it also shows that the relationship is moderated by the legal system. So let me walk you through that, but then at least you have the main takeaway here. So how did I do this? I have a look at 39 out of 48 countries in sub-Saharan Africa for the years 1992 to 2019. And I use three sources of data. So first, for the household level, I have a look at the demographic health surveys. And these surveys include variables like child marriage, but also contraceptive use, unmet need, other things like household characteristics such as age, education of household members, and many more. Then I have a look at the subnational level by means of the Global Data Lab, which is aggregating data. So, for example, I have data on the percentage of households having a phone in the region, and this then can be used as a proxy, for example, for the infrastructure in the region. And I do the same for many other variables. And then finally, I have used data from UNICEF for the legal system. So, for example, there's data on the legal age of marriage in a specific country, but also whether there are exceptions to this law, and also the centralized system, many more than that. But when I combine everything, I have a final data set of 175,000 married women aged 20 to 24 living in 807 subnational regions within 39 sub-Saharan African countries. So what will I do with this data? First of all, I will make a visualization by maps so we can have a look at national and subnational differences. And after, I will have a look at the intra-class correlation and three-level, multi-level logistic regression analysis. So I will do that by this equation, and I know it looks very complicated, but I just wanted to show that I estimate this binary contraception response, so I have many, but I estimate these by using a fixed intercept. I have many household level variables, 40 actually, and then I have subnational regional variables and national level variables, and then of course the focus variables, right? Child marriage, the legal system, and the interaction between the two. And I also control for country and year fixed effects. So when we have a look at the first results, so I'll have a look at the maps, then, and we look, so on the left it's child marriage, then in the middle we have ever used modern contraception, and on the right we have the unmet need for contraception. And when we have a look at the left and the middle map, we can see that there's kind of a pattern going on, right? So the situation seems to be the worst for child marriage in Central and West Africa, and for modern contraception as well. But when we have a look at unmet needs, there does not really seem to be a pattern, right? It's more like a chaotic whole or whatsoever. So then I was kind of triggered, and I had a look at the intra-class correlation. So this means that I investigate how much of the variation can be explained by each level. So for contraception, we can see that 23% is explained by the national level and 12% by the subnational level, Well, if we have a look at the unmet need variable, for example, then only 3% can be explained by these levels, and the rest is explained by the household level. So there seems to be different mechanisms going on there, which could be very interesting to have a look at later. So then my first regressions. When we have a look at child marriage, we can see the unexpected result that I was talking about earlier. So the regression results show that child marriage leads to more use of contraception and more use of modern contraception, but less use of traditional contraception. So this is unexpected, but as I said, I think that the situation is a bit more complex than that, right? And that the legal system also has a role. So then if we look at the interactions, so the lower part of the graph, and for example at exception, then we can see that there is a negative effect, meaning that, and the negative effect of exception is, for example, bigger than the child marriage effect. This means that if there's exceptions, there's actually a negative effect for child marriage on contraception, meaning that they use less. So this also happens, for example, for modern contraception and for traditional contraception the other way around. For unmet needs, for spacing and limiting, there's no significant effect found, so we cannot really say anything about that. But regarding contraception, we can say, well, okay, there are unexpected effects like in previous research, but the situation is a bit more complex, right? It's not just this direct relationship, there's indirect context factors. For example, the law, which I had a look at, but it could be others, right? So to wrap it up, previous research had found this inconsistent evidence. So they say, well, child marriage does not only lead to less contraception, but also sometimes more. Well, there's not really this clear relationship going on. And this Van and Koski paper, they point towards context factors. So that is what I did in this study, and I mainly focused on the legal system, right? And why? Because this is an essential part. For example, UNICEF is focusing a lot on this. And as I just showed you, there's, again, these unexpected effects. So child marriage on itself leads to more contraception, but this is not the whole story. So the legal system has a moderating effect, as I just showed you. And actually, as soon as the legal system is not comprehensive or complete, and there's loopholes, for example, then the results are actually negative. Right? So then the child marriage, if a child is married, and this was because of loopholes, for example, then the use of contraceptives is less. So the main point is the story is more complex, right, than in previous research was shown. So then up next, of course, this is a work in progress. I would like to add the mixed surveys because some countries are missing, and then I could create a more complete picture of sub-Saharan Africa. And I would like to do some robustness checks. So for example, I also think that there might be an age effect going on, so different effect for young women and older women. So I would like to have a look at that. And also I would like to investigate the age of marriage at 16. So now I have focused on 18, but I think it could be interesting to have a look at 16 and younger as well. Yeah.
Thank you. Thank you, Anne. We had 3 different presentations on the same issue, looking at pathways to pregnancy in Southeast Asia and 4 countries within and outside Union, dealing with pregnancy in 2 settings, in Niger and Bangladesh, in the context of COVID and trying to postpone first pregnancy and increasing contraceptive uptake. And here looking at, what are the effects of the legal system, the socio-cultural system, and of course it's a little messy because all these are kind of put together, and just having legal systems and policy systems is not enough. Application of those systems is also, it's good that you ask these questions because sometimes we have these received wisdoms and we kind of say, this is what it is, and it's nice that you challenge and ask. Even if you come back with very similar conclusions, this is an exercise worth doing. We have a few minutes if we wrap up. Anne has already invited inputs. If you want to, she can talk to you, give her your contact details in case you want to provide inputs. Do you have any quick comments, suggestions for her? And then I'd like Anne, Arvind, to take 2 minutes at the end to talk a little bit about Girls Not Brides, the Crank Network, because you all come to learn from research findings. How can you continue to be part of this network? Yeah? Yeah, please. If you want to have your hand up, no problem.
Thank you for this wonderful presentation. And I'm going to, what I'm sharing is from the perspective that you're looking at sub-Saharan Africa, right? Now, I come from Uganda, yeah? And we did a social norms exploration, yeah, in the southwestern region. And of course, there were issues about the legal system and child marriage, yeah? And we found out that actually the actors in the system, because the legal system, people operate it, right? The police or the judges, you know, or whatever. They were also influenced, yeah, by the social norms. So they couldn't administer justice because the community would also identify them and say they are the ones who are stopping our children from getting married. So social norms, yeah, also influence the actors in the justice system.
I think that's true everywhere, you know. We are health workers, teachers, lawyers, police officers are all members of the community. My colleague Egypt is from Egypt. You know, who does female genital mutilation in Egypt and Sudan? It's health workers. So, you know, there are, do it in, you know, in the context of health facilities. And their argument is it's better to do it in the health facility than outside. So, you know, everyone comes into this. That's why you have this web of silence when you have sexual abuse as well. You know, who are we to challenge those who empower? Thank you for your comment.
Thank you so much. It's a very interesting research. So my question is on the legal marriage system itself, because I know it's a very brief presentation, but I didn't understand what you mean by comprehensive. When you say comprehensive, what does it include, whether it is about practice, and also in the sub-Saharan Africa, actually, we do have a lot of plural legal systems. So sometimes, I mean, I have seen the UNICEF one, so they focus on the formal legal system. So whether you have considered this part also. Thank you.
Law. Yeah. Customary law is very important. So one of the suggestions is, are you going to add a layer on social norms? And you know, there are plural systems. Last comment here, and then quick reactions from you, Anne.
All right, thank you very much. On your very first presentation, I think you did excellently well. For me, seeing that you have plans for next step, I don't know if you can include, there's something I've noticed when we come to international gatherings, countries are represented by ministries at the federal level. And then these ministries don't control the states where implementation would take place. And then when the conferences are done with, the federal level representatives take back these policies to their country after agreeing to be part of it, you see nothing happen. So how can we start looking at steps to bridge that divide such that it will be the states that will be making this pledge to have these policies implemented in the states?
You know, you are from? So we've been having discussions with the Federal Ministry of Health in Nigeria to, you know, they've developed a new adolescent health strategy, and it's a wonderful strategy, but Nigeria has always had good strategies. The problem has been the implementation. And it's not just Nigeria, it's true with India, it's true with Ethiopia. So what we are saying is you need sound policies and strategies, but implementation, particularly in the context of decentralization, where budgets are decided at the district level, that's where you need to work. So increasingly we are moving there. But let's remember, let's not be too impatient. We haven't had money for adolescent health implementation till recently. It's been a Pathfinder project and a Save the Children project till now. It's only now that governments are starting to put money for implementation of adolescent health programs. Till now it was childhood mortality and maternal mortality. Now is where the global program on child marriage focus, for instance, very much is at hotspots, looking at where they need to work. So your point is very well taken. Any last, and do you want to make any responses about the comments made to you or no?
No, well, they are very valuable, and I will have a look whether I can include something on enforcement at lower levels, and also whether there is, I think, data on whether the centralized systems are decentralized. So that could be very interesting then. And responding to your question, what I mean by the comprehensive legal system is that they also address these loophole things, and also that there's just there's a clear law and not, for example, two, like customary law and civil law, and then it's confusing, for example, for households which law to abide by.
But that's also the reality in many places. Huh?
But some part of the customary law is also recognized in countries' constitutions, so that's why they're...
Yeah.
So
Okay.
it is complex, it's messy, but I hope
Yeah.
coming here and presenting has given you the confidence to come and present again. Bravo. Well done. Arvind? And your colleague from Nigeria, I didn't get the name. Come.
Yeah, you want to?
Come on.
We can do it together.
Decolonization. We need
So I guess I can start by introducing a little bit about Girls Not Brides, or do you want to do that part and I can talk about the crank? No? So for those who don't know, Girls Not Brides is a global network of civil society organizations who are working collectively to end child marriage. We have 1,600 members currently in over 100 countries. We're made up of a really diverse group of organizations, some who are working on a health angle, some more from an economic perspective, some more on education, and so it's a very broad church. And the child marriage, well, actually to back up, I'd say what we try to do collectively is advocate for solutions to end child marriage at both the national, regional, and global levels. And we also act as something of a repository of information. So our website acts as a bit of a database for the latest learning on child marriage, the latest data from UNICEF, and we try to aggregate that knowledge. We do a lot of dissemination with our members, to help them use that information and data in their own advocacy and messaging. So the Child Marriage to Research Action Network, which is known as the CRANC, is a relatively new initiative that we host with the Global Program to End Child Marriage, which is obviously UNICEF and UNFPA. And the real purpose of the CRANC is to bridge the gap that has for so long existed between child marriage researchers and practitioners, so those who are actually working on programming and policy advocacy. Because we know that for a long time there's been kind of a repetition of a lot of the same mistakes, and often research is produced and it's fantastic, like we heard today, but it's often not used. So what we're really trying to do with this platform is bring child marriage practitioners and researchers together to share that information at the earliest stage possible. So we have quarterly phone calls, which brings together everyone who's signed up to the CRANC to share latest research from our members, but also from across the partnership. So sometimes we might have someone from a UN agency, or sometimes we might have someone from a community-based organization, to share the latest research, and then we can have a discussion about the implications. So it's really, a large part of it is about dissemination. I think, as Chand was also saying about decolonization, we also really want it to be a platform where we can bring the work of our members, because INGOs have often dominated the knowledge production when it comes to child marriage, but I think in general. So we have a lot of members who maybe don't have as much money or capacity to document their work, but where they are doing that, we're trying to bring it as much as possible into that global space, so it's not just dominated by peer-reviewed publications. The other aspect of it is kind of tracking and knowledge management. So if you sign up to and I encourage everybody to sign up, so everyone who's working on child marriage is welcome to join, whether you're a practitioner or a researcher. If you sign up, then you have the opportunity to add information about any research that you're working on or you've recently published to our global tracker. So the global tracker is then updated quarterly and is published and shared on our website. And the purpose of that is really for us to keep track of the gaps that are emerging and continue to exist in the child marriage research landscape. So that's kind of a follow-on from the last meeting we had in Geneva. Maybe Chandra, you can speak to it if you like.
And to say that, you know, if there are future meetings, you'll get a newsletter, and if there are future meetings, they can invite you to come and speak at the It's a way of sharing information. Maybe you should share the website.
Yes, so everyone can sign up. If you go to the Girls Not Brides website, it's just www.girlsnotbrides.com, and then if you search Crank, then it will come up, and you can sign up and register there. I think I've talked a bit about Crank, but do you want to talk about learning calls?
Yeah, so we're just adding a little bit to the learning calls. We're piloting gender transformative approaches to end child marriage in Nigeria and Mozambique. It's funded by UNICEF through the Spotlight, UNICEF and UNFPA through the Spotlight Initiative. And in the past few months, we've worked on some learning tools around GTA to end child marriage. On the 24th of this month, we'll be having a learning series that is focused on, you know, what we have learned so far from our partners in Nigeria and in Mozambique. So you're welcome to register, to join, and by December or early January, we'll be publishing 2 materials. One is more focused on the Africa, you know, the African region and what we're learning from working in both countries. And then the other one is like the GTA reports for Nigeria and for Mozambique that are specific to what we have learned in each of these countries around using gender transformative approaches. Thank you.
As a member of the Crank Network, I already got an automatic notice of the webinar and the date, and you can sign up. Thank you, Ms.
Just also to say quickly, if you sign up to the Crank and you add information of your work to the tracker, then it will be published on our website, and if you share a link, we'll also publish the actual publication itself on our website as well. So particularly if you're coming from a smaller organization that doesn't have so much reach, I know that can be a valuable thing.
The UN program on child marriage also publishes a research digest. So we worked very hard to make sure that research doesn't just only feed into a peer-reviewed publication and stay there, but get in. But we all have come together for these 3 smart young women. Can we invite them here and give them a big hand? Come. We need a group photo of you. If you give me your phones, I can take